be held by MRI. Sometimes it really helps you to direct to the muscle biopsy site, but it obviously you're not going to use it in routine, but in patients who are complicated and you can't get to the diagnosis, you can use an MRI, and wherever it is lit up, you can biopsy that site. And obviously that's not the routine, I have to tell you that. I'm not going to talk about all these, but whenever you are, these are mimics of myositis. So you have to make sure that your patient is not suffering from amyotrophic lateral sclerosis, hypothyroidism, hyperthyroidism, hyperparathyroidism, infections, which could be parasitic, which could be bacterial, which could be viral, metabolic myositis. And there's like a list of metabolic myopathies, which is a long, long list, but we all know that statins can do it, colchicine can do it, clofibret can do it, and metabolic myopathies, which are congenital, for which we need special testing, and obviously muscular dystrophies. Now, once you have made the diagnosis of myositis, you should know that it is a rare disease, and it's a heterogeneous group of diseases, and their management is really difficult. I would, like to see what my colleagues have done, but I would really like to have our data shared on patients who have polymyositis. And the practical recommendations, I have to tell you, that haven't changed much over the period of years. It's the same story. Give them steroids, give them Imuran, give them methotrexate, give them tacrolimus, but nothing new has come up. And I looked at this and I was like, what is new? The thing is this, that patients, we have to know whether patients have any extraskeletal muscle involvement, as I said, lung involvement, pharyngeal involvement, the duration of the disease for which they have this, if they have a longer duration of disease and they were not treated properly, if they have extraskeletal involvement and the interval between onset of muscle weakness and the start of treatment is prolonged, then they have a poor prognosis. As I said, that let's go on to this. Intravenous immunoglobulin, जब मैं अपनी fellowship कर रही थी तो उस वक्त बड़े we were so excited that we have this IV immunoglobulin and you have to give it, and every month we used to give it to the patients and they would do so well. But then everybody realized that as soon as you finish the IV immunoglobulin, they just sort of shot back where they were before. So it was, I think, lost, it wasn't that popular anymore. But this latest report, which was published in Chest, Ahmed, I'm your teacher, but we have to follow rules, so you have to tell me the 5 minute so basically, interstitial lung disease, which was associated with these two, which has a poor prognosis, and we don't have an optimal treatment of this, but this showed promising improvement in patients who were given 3 doses of IV immunoglobulin, which was 2 grams per kilogram body weight, and they did very well and a very good response. So this is something which one can look into. The other thing which was also supported this, that IVIG as an add-on treatment with cyclosporin or MMF is useful in patients with myositis, even those with refractory disease, and sometimes they do respond to the treatment but they relapse again. So in such situations, although it's a very expensive treatment, patients do respond. This is very difficult to treat, and people have tried colchicine, probenazide, bisphosphonates, local injections, but people are very unlucky if they have calcinosis, because it's very, very resistant to treatment, and sometimes does respond to shots, and it's more so in juvenile idiopathic myositis. And rituximab, because we just saw that the B cells are involved in dermatomyositis and juvenile dermatomyositis, so it holds promise, and there's a large trial on rituximab in dermatomyositis and polymyositis, and the results are waited. While we are managing patients with polymyositis, we must follow them up closely, especially if they are losing weight, because this polymyositis, this link with malignancy is been proven beyond doubt in several studies, and this was a retrospective study, a 21-year retrospective study, which showed that patients who had dermatomyositis had at least 10 times the risk of developing malignancy, especially ovarian tumors. So in females, we should be looking at them with a pelvic ultrasound and